This week we're going to look at euthanasia. As the picture to the right suggests, euthanasia is a can of worms. So our plan here, we're not going to be able to give an exhaustive account or all of the arguments for and against euthanasia, but we're going to start by recapping Beecham and Childress's remarks with respect to Aiden dying, and then we're going to look at two thought experiments that Rachel's provides, and then we'll look at Rachel's article and then Tierlay's article. Let's begin by recapping Beecham and Childress's views. And before we do this recap, I just want to stress again, this is Beecham and Childress's position, not the accepted, mandated, obligated position of physician-assisted suicide. So just so you know, I'm not telling you that this is the correct view. Instead, this is what Beecham and Childress are arguing. And it's a common position within this literature. So Beecham and Childress argue that physician-assisted suicide is part of medical care, and so in that sense, there should be some obligation of the physician to provide this as like any other type of medical treatment. Then they go on to talk about how the principles of respect for autonomy and beneficence and the virtues of care and compassion all offer strong reasons for recognizing the legitimacy of physician-assisted death. And then after that, they talked about arguments suggest that causing a person's death is morally wrong when it is wrong because an unauthorized intervention thwarts a person's interests. So the idea here is that if we make the decision to euthanize a person, independent of the person's own decision-making abilities, so if they have autonomous decision-making capabilities and they don't authorize euthanasia, or if they're in a coma and they don't have the capacity to authorize an intervention, then it seems like making a decision on behalf of a incompetent patient sort of thwarts that patient's interests. And so that's what seems problematic when it comes to euthanasia. However, Beecham and Childress are going to say that the fact that autonomous requests for aid in dying should be respected in some circumstances does not necessarily entail that all cases of physician-assisted death by the patient's requests are justifiable. And if you remember, we were talking about the Kevorkian case where a patient had a diagnosis of Alzheimer's and was really anxious about that diagnosis, and so she reached out to Kevorkian, who provided her with the means to end her life without necessarily doing any investigation on his part, where like he just didn't confirm the diagnosis. He didn't make sure that the patient had a psychological evaluation to make sure that she wasn't just experiencing a lot of stress. She still had a lot of time to before the disease would sort of really take effect. And all of those factors, Beecham and Childress argue, are good indications that our responsibilities, that Kevorkian's responsibilities to the patient were not upheld. So to sort of recap all of that, right, Beecham and Childress think euthanasia or physician-assisted suicide is part of the medical field. It should be like any other treatment if it's authorized or if it's in the patient's best interests. And a moral argument can be given that it's not thwarting the person's interests in a certain way, then it seems justifiable on Beecham and Childress's account. However, they caution that not every case in which it seems like a patient is authorizing end-of-life treatment is it necessarily permissible, that there are a number of criteria that should be met before such a treatment is made available. Let's take a look at Rachel's rather morbid example here about Smith and Jones. So the idea is that Smith and Jones will have this 6-year-old cousin that is going to take a significant chunk of the inheritance. And what Smith and Jones both want is for the cousin to go away so then that they can get this large inheritance for themselves. So Smith sneaks into the bathroom as the cousin's taking a bath with the intention of killing him, and Smith ultimately drowns the cousin in the bathtub. I know, like I said, morbid. In the case of Jones, Jones is thinking the same thing. He wants to make sure that he gets a large inheritance, so he's going to decide to kill his cousin. He gets into the bathroom and he finds that his cousin had fallen and hit his head, and now he's drowning in the bathtub unconscious. And Jones just decides, well, I guess I'll just let nature take its course here. So the question is, are Jones's actions any less objectionable than Smith's actions? So just because Jones doesn't actually physically cause the cousin's death, is Jones any less responsible or any less exculpated for what he does? So I hope that your response to the previous thought experiment is that both Jones and Smith are terrible people, at the very minimum, right? But the whole idea of the thought experiment is to show this distinction between active and passive euthanasia doesn't really mean what we think it does, why one isn't just as clearly or justifiable as the other one. And this is something that Beecham and Childress also talked about in their discussion of killing versus letting die, that it's ultimately a distinction that is made based on causation rather than moral considerations. So Rachel's is going to provide us with a similar argument as Beecham and Childress insofar as that there is no reason to justify some actions because they count as letting die versus killing. Rather, in some cases, it might be morally obligated to, or we might be morally obligated to intervene and assist with somebody's death. And in some cases, it seems clearly morally wrong to stand by and not do anything, just because the death is ultimately desired. So here, the idea of active versus passive euthanasia is the idea that it is permissible, at least in some cases, to withhold treatment and allow a patient to die, but it is never permissible to take any direct action designed to kill the patient. So again, it's causation based. And so Rachel gives us 4 different considerations here against this distinction. The first one is that active euthanasia is in many cases more humane than passive euthanasia. He gives us the example of somebody with throat cancer who's in terrible agony, that once the decision is made to not prolong the person's life, that active euthanasia is preferable to passive euthanasia because passive euthanasia is going to just lead to more suffering. And so it would seem like it'd be in the patient's best interest to intervene and provide them with some relief. They also talk about this case of babies with Down syndrome, but I'm going to talk about with respect to this second part, which is that the doctrine leads to decisions about life and death on irrelevant grounds. So the idea with this case is that it seems impermissible to cause the death of a baby with Down syndrome simply because they have Down syndrome. But some babies with Down syndrome are born with these intestinal blockages, which if they're not surgically fixed, then they're ultimately going to die. And if somebody wants to, not if somebody wants to, that's portraying this in the incorrect light. If somebody decides to not have a physician take care of this intestinal blockage and just allow the baby to die, and the argument is given, well, that's naturally what happens. We're not intervening. It's not our fault. This is just passive euthanasia. We're not directly causing it. It's a medical condition. What Rachel's is saying here is that the ground for the decision that ultimately leads to the child's death, although it's acting that there's just some causal relationship here, that one directly causing abortion or something like that, which causes the infant's death, I guess the fetus's death, I should say, that'd be correct. That would be directly causal. It would be considered killing, but like not addressing this intestinal blockage is letting die. And why would one be permissible than the other? Because both of them have the same intent and both of them have the same outcome. Which gets us to the third part here of Rachel's argument, which is that the doctrine of active versus passive euthanasia rests on this distinction that has no moral importance whatsoever. The causal connection is not what's important. Rather, it's the intention and the outcome, and that's where we are going to make our moral evaluations. And so this is where we see that the Smith and Jones cases sort of show that the distinction between active and passive euthanasia isn't one that ultimately removes the blame from the person who just doesn't intervene to save their cousin's life, that they both have the same intention and they both I guess the outcome is the same in both situations too. Neither one is more or less morally blameworthy. Then finally, the idea is that the most common arguments in favor of this doctrine are invalid. The bare difference between killing and letting die does not make a moral difference. This is sort of connected to what we were just talking about. But what Rachel's is going to say is that it's not exactly correct to say that in passive euthanasia the doctor does nothing for the doctor does something, which is let the patient die. If a doctor allows a patient who is suffering to die from a curable illness, then the doctor is certainly blameworthy for the needless death of the patient. And doctors should be concerned with the fact that the law is forcing upon them a moral doctrine that may well be indefensible and has considerable effect on their practices. So Rachel's is talking about addressing the AMA policy here. So it might be necessary to discriminate between active and passive euthanasia to satisfy the law, but it should not be invoked as a moral justification. So obviously euthanasia is quite regulated by the law, and if you remember, hopefully you do, legal norms are different than moral norms. And so what Rachel is trying to get at here is that if we're going to provide a justification for a patient's death or aid in dying or euthanasia, that we would hope that we can provide a moral argument for or against doing it that can stand up to our moral reasoning, rather than just appealing to what the law states, because obviously laws and policies change over time, and we are trying to deal with these objective moral facts. So now let's look at the second article. The idea here is that Dutierley presents these projected consequences of physician-assisted suicide that are used in the literature to criticize the implementation of physician-assisted suicide, and then responds to each one of these different projected consequences in kind to show that they aren't really actually justifying the prohibition of physician-assisted suicide. So the first projected consequence is that it's just going to lead into a dystopian future where everybody sort of breaks the law and just does whatever that they want, or there are going to be different laws in place that don't really uphold or considered moral judgments. And so in response, against this criticism is that if the practice is legal and out in the open, it is actually easier to put safeguards in place and make sure that they are followed. So if it's more regulated by laws and permitted, then people are not going to just work around the laws to get the type of care that they need. So this idea of slippery slope argument can actually be turned against itself to say that, well, no, if you do more regulation and put it out in the open, then you'll actually prevent this type of degradation into a certain state of medicine that, or laws that permit certain acts that we don't think are consistent with what we expect from healthcare providers. The second projected consequence has three different parts here. So it's abuses of, the idea is that physician-assisted suicide might be abused in certain ways. So first, abused by patients might ultimately be pressured into pursuing euthanasia by other people, so that would sort of violate their autonomy. And in response to this, Dutierlez says that physician-assisted suicide laws can be seen as granting physicians negative rights of non-interference, but no positive rights is invoked whatsoever. So it's about looking for competency, and the idea here is that physicians would be providing something without necessarily forcing them or forcing the patient to decide one way or another. It's the authorization of the patient that makes it possible. So that's the response to the pressuring criticism. Then the next issue with abuses would be vulnerable groups. So in response, the idea is that euthanasia has been most common among highest socioeconomic status, so people who are lower socioeconomic status. The evidence doesn't bear out that they would just seek euthanasia as a way to escape those conditions. Instead, the opposite seems to be true. And then also underneath this abuses heading is people without insurance. So people without insurance would be pressured into sort of pursuing euthanasia in this respect. And the response here is that the statistics don't really actually support this claim either. Then after that, another projected consequence is this idea that it will ultimately corrupt medicine and its practitioners. And in response, Dutierlez says that, let me see, there we go. There is no evidence to support this claim either. Then the fourth one is that it will ultimately weaken the prohibition on killing in healthcare. And here there's a decline in homicide and violent crime rates in Oregon, where the Oregon Death with Dignity Act is sort of in place. So that's sort of the model for euthanasia that's being used here by Dutierlez. And the whole idea here is that the statistics don't seem to bear out this idea that people are just going to be more accepting of killing just because physician-assisted suicide is permitted. But I think Dutierlez also recognizes that it's not conclusive, since the causal factors cannot actually be isolated. So the fifth part here, or the fifth projected consequence, is that patients will give up too easily. And here Dutierlez says that because Oregonians, I hope I pronounced that right, and citizens of the Netherlands know that should life become unbearable, they have the option for a physician-assisted suicide. They can actually focus on the life that they have left. And so that could be actually more of a freeing experience, and so allow them to enjoy more life, or the life that they have left, because they don't have to be concerned about what's going to happen towards the very end. That's the argument against that. Then we have improvements to care will stop, and this obviously doesn't seem very realistic, because evidence suggests the opposite, that palliative care and terminal care are actually always trying to be improved, and physician-assisted suicide could just be one part of it, but doesn't necessarily have to impact the development of other types of treatments. And then finally, we have people will start to fear hospitals, and here Dutierlez says that there's no real evidence to support this claim either. If the practice is out in the open, it seems like it's easier to put safeguards in place and make sure that they are ultimately followed. That's the idea that Dutierlez is trying to give us here. There are two additional considerations that are covered. So the first one is the gendered critique from Wolf, and in response, Dutierlez says that evidence does not necessarily support this concern, that what is Wolf's criticism is that women will feel more pressured into doing it because women are expected to be more self-sacrificing. So evidence does not necessarily seem to support this, but we want to make sure that any time in which somebody is choosing physician-assisted suicide, that their autonomous consent is present, but also do not want to be paternalistic. If we just say that women are not allowed to have access to end-of-life care, I guess I shouldn't say end-of-life care, aid in dying care, then that's equally as paternalistic by the same standards, because if women are always considered to not have the capacity to make this decision for themselves, it seems like we are basing that argument off of gender norms rather than moral norms. Then there's also the deontological arguments against physician-assisted suicide. Ideas being here that the physician's intent is to save life, not take it. Response here is that the physician's intent should be to alleviate suffering and promote the patient's best interests. And then the other side of this deontological critique is that killing is inherently wrong or against God's will, against natural inclination to continue living. And this commits the naturalistic fallacy, right? That just because something happens in nature doesn't mean it's necessarily morally justifiable, or that it's moral in nature, I guess I should say. And it's difficult to see how these considerations apply to those who seek physician-assisted suicide, since they are diagnosed as terminally ill with less than 6 months to live anyway. So that is the quick flyby of me just recapping this to you. Obviously, you could do the reading for yourself, but I wanted to just talk about each one of these in case they were a little bit difficult to understand. But now I just want to reflect on these issues, or not really these issues, but these considerations. So why did I pick this article? Obviously, it doesn't really dive into any specific moral argument. Instead, it's just trying to familiarize you with a number of different reasons given against physician-assisted suicide. A lot of the responses that Deterle gives us, they're just based on this idea that the statistics don't bear them out. That's not really a moral argument for or against them here. And so why I selected this argument was just to give you a familiarity with these different projected consequences and see how we might respond to some of them, just so, again, you're familiar with them. I think the important takeaway here is the difference between law and morality. I've stressed this on a number of occasions. Legal norms and moral norms are not the same, but I'm not trying to tell you that you should violate legal norms because you have stronger moral norms that you think are in play. Instead, I think the correct view here is one that's expressed in other parts of the literature, especially with conscientious objection, that, you know, if you think that something is inconsistent with moral norms, then it's not your right to violate laws. It's your job to try to rewrite laws or advocate for different laws that are more consistent with those moral norms. So just really want to stress this idea that there's a difference between law and morality. And even if we find ourselves arguing for something that is deemed illegal, it doesn't mean that you are justified in doing an illegal action. Instead, it seems like the proper route is to address those legal norms within the right arena, which would be laws and policy and things like that, getting that stuff changed. So what is a healthcare provider's ultimate responsibility? What I really like about one little piece here in Deterle's article is this response to the deontological critique. So the physician's intent is to save life, not take it. And Deterle responds, well, the physician's intent should always be to alleviate suffering and act in the patient's best interest. I think that's consistent with what we've been saying throughout this semester, especially as we were reading Beecham and Childress, that, you know, there's a difference between procedure and product, and what is motivating our procedure. It's usually crucial that our focus is on ensuring that the interest of the patient always comes first. What that looks like is going to require critical reflection and navigating these different moral arguments. And so ultimate responsibility does seem to be to the patient, and upholding this responsibility to ensure that their best interests are upheld, I guess is what I'm trying to say. Sorry, not a super cogent thought there. And then finally, could you reason through the four principles that we were talking about for Beecham and Childress? So respect for autonomy, beneficence, non-maleficence, justice, to justify your actions if it were ever called upon you to provide physician-assisted suicide. Not that you are necessarily obligated to do it, but could you effectively use that to articulate your view or your reason for or against providing it. I think that's the key thing here, is can you use the tools in your toolbox that we've been developing to ultimately provide a moral argument that gives you the justification for your role as a healthcare provider. Now let's do our customary summary. So obviously we started with Beecham and Childress and we were asking, is aid and dying part of medical care? Beecham and Childress would say it is, but other people would say no, it's not. And the point of bringing up this question here at the end is just to dovetail off of what I was just saying, which is that it's really difficult to navigate these really messy situations within the healthcare field without having the sort of moral tools to be able to diagnose and think about the context of these requests and the context of your role as a healthcare provider. So this is a common motivation for this dialogue or this discussion on physician-assisted suicide is aid and dying part of medical care. Then we looked at the arguments that are we looked at why passive and active euthanasia, this distinction is inadequate in Rachel's, and we used our thought experiment of the Jones and Smith drowning the cousin, where Jones is actually causally making the death occur, and Jones is just passively walking by, and it seems like both of them are equally morally blameworthy to the same degree. And that's the basis of sort of Rachel's core argument here, is that there really doesn't seem to be any meaningful moral distinction. There we go. Between active and passive euthanasia. And then we were just talking about there is not very much evidence to corroborate the negative consequences that critics of physician-assisted suicide often predict will happen if the act or treatment is permitted, but this doesn't necessarily mean that all physician-assisted suicide is inherently right. It just means that the arguments that are used are not sufficient to justify the abolishment of physician-assisted suicide outright. So again, this is a very messy topic. I'm not trying to act like I'm giving you the correct way to respond to this. It's not like you can take this lecture and now you feel comfortable in knowing how you're going to respond to any request for aid and dying treatment if you are ever put in that situation. But the key thing here, based on the readings that I picked and what we've talked about in the past with Beecham and Childress, is just to sort of drill into you or really emphasize that the best that we can do is develop these tools and be able to understand these arguments, so then we can articulate our own position based off quality moral norms and quality moral reasons to build these moral arguments. And I'm not trying to, again, tell you that it's a good idea to violate laws if your moral arguments seem to suggest some course of action that's inconsistent with what the laws are. Definitely not trying to tell you that. Instead, I'm just trying to tell you how we might reason through these, because, again, being in the healthcare field will take a toll on you, at least based on every physician and nurse that I've ever talked to. It can be very demanding, very exhausting, and one of the best ways to navigate all of those challenges is to make sure that you are best prepared to rationalize what's going on for yourself.